This is Sue Jusell. I'm the Harwich Town Nurse. I work with the Harwich Council on Aging. And here I have with me is Kimberly Irvine. She is a nurse practitioner in this area and looking to do some outreach and just educate the community on some public health matters that when we were together we discussed some things that come up frequently, and she thought she might clear some questions up for us. So welcome. Thank you for being here today. So one of the things we had discussed about was now that with Medicare you can have a physical exam every year, is it important? I have people saying, well, I never had one, why do I need to have one? So how often should somebody have a physical exam?
Well, typically from ages 3 and up, it's recommended annually, and you mentioned Medicare. With Medicare, they're not called physicals, they are wellness exams.
Important to know.
Yes, which is essentially the same as a physical.
Okay. And then you also mentioned like a universal screening. What does that mean to the general public out there? What would a universal screening be?
Well, it's something that we bring up in our wellness exams or physical exams, and it's it's really talking about the things that would apply to everybody. Of course, some are gender specific, like mammography, colonoscopy, pap smears, bone density, blood pressure, screenings for obesity, sexually transmitted infections. That's what is considered a universal.
So are some of these exams, like what ages would you really start looking at bone density? Is that something at a younger age now? Or?
No, I mean bone density is recommended post-menopause, because with the estrogen changes that happen with menopause, it can have effect on the bones. So we normally like to get a screening right after menopause, and then typically every 2 to 3 years.
So you have like a guideline?
Yes,
Kind of like getting an EKG.
Yes.
I know I'm in my 40s now and I've never had an EKG. At what point should I probably get one? Should I have a baseline or? There are governing bodies that govern a lot of the universal screenings as far as age recommendations. EKG kind of falls into one of those gray categories. In my practice, we do it annually on people 40 and up. Oh, okay. And I guess each practice would have their own decisions on what they would feel.
Exactly, yes. Everyone's physicals and even some of the screenings, though we typically follow the governing bodies that are variable, of course.
Okay. And like blood work, especially for people who are healthy. Do they need to get blood work every year, or would you check blood work, or how do you feel about that?
Again, under the Affordable Care Act, things associated with wellness or health prevention, like physical exams, we can order blood work, and it's typically little to no cost. We look for things like high cholesterol, kidney function, liver function, complete blood count, general chemistry is just kind of screening for anything.
Great, so it's all prevention.
It is. Typically, yes.
It's typically to find something that might be wrong so that way you can identify an issue early on.
Exactly, like some patients will have, a slightly elevated cholesterol. I'll see them for their physical exam, we'll talk about it, and with that I feel like they can make some healthy changes for future life, hopefully, and prevent things like heart attack and stroke, etc.
And I know as a nurse practitioner, you certainly like the education piece.
I do.
As well as you're here to do that.
Yeah.
So what does a typical physical exam cover? If somebody were to go to their primary care office, and I understand now that each office will probably have a little bit of a different protocol.
Of course, yeah.
But for example, in your practice, what might you be looking for?
Typically we start with kind of, general well-being questions, work, alcohol use, smoking, have you had a recent eye exam, anything going on. We look at vital signs, blood pressure, which is a universal screening, height and weight, again, kind of screening for obesity, pulse ox, and you mentioned the EKG. We do it 40 and up, not every practice
pulse ox,
does.
people don't know what a pulse ox is.
Measuring your oxygen level, looking for anything that shouldn't be there with that. And then just do like a review of systems, so kind of break it down systematically, skin, cardiovascular, asking certain questions to kind of prompt, is there anything going on? Again, kind of screening for disease pathology, anything along those lines. And then the physical exam, kind of typical, your head to toe, looking at generally everything.
Okay. I saw a patient this morning who was very happy to have had her carotid arteries checked. Is that something you do on a routine basis?
I
or is
do.
that age appropriate for certain
Was it
ages?
an ultrasound she was talking about,
No,
or was
it
it
just
listening?
during a physical exam, and she was impressed by it.
Yes, I typically do listen to the carotids, and that's kind of a quick and dirty way to screen for buildup of plaque in the carotid arteries if you hear certain sounds that shouldn't be there.
And so from there, if you heard something you weren't, you thought that might be dangerous, you would then order like an ultrasound or something.
Yes, to screen for it.
Okay, which is not invasive either. So again, it's all preventative, nothing scary about it.
Right.
Excellent. All right, and then the general question that you get like time after time is, what is a normal blood pressure? And are there guidelines to go by?
Yes, there are guidelines to go by. The JNC-8 or the Joint National Committee. We used to go by the JNC-7 for a long time, and then JNC-8 came out, and they actually
revised.
They revised a couple of things. So these are relatively new, but 60 years and older, the recommendation has changed that an at-goal blood pressure would be less than 150 on the top number and less than 90 for the bottom number, unless they have additional risk factors, things like diabetes, known cardiovascular disease, etc.
So unless a doctor says there's an exception here, this is what they're looking for. Can you just repeat that again? Just for the listeners that are really trying to hear that.
Sorry, speaking too quickly.
No, you heard it. You said it beautifully, but people like to hear things again.
Sure.
So just for a typical guideline, and this is a very typical guideline. It's just a guideline, gives a doctor and nurse practitioners a guideline to go by. So unless you've got a diagnosis that's going to put you outside of that guideline, for the top blood pressure number they're looking for.
If greater than 60 years of age and no other risk factors, it's generally recommended to be less than or equal to 150 for the top number or systolic blood pressure, and then less than or equal to 90 for the bottom number or diastolic blood pressure.
Excellent.
Yeah, I think that answers your question.
Good. And
then if less than 60, we tend to be a little bit more aggressive, again, in the absence of other disease pathologies. If less than 60, the recommendation is less than 140, meaning 139 or down, and less than 90.
Excellent. Well, I think that people like to have an idea as to where they are in the general scheme of things. And we did just quickly touch on estrogen a few minutes ago. I know that this is kind of your thing, and we weren't really going to discuss it today. But if you were to say anything about estrogen, if we're looking at perimenopausal women in the audience here, what would you say to them as a general overview about estrogen, who knows nothing about it yet?
The general overview, I would say, is that there's no recommendations. If you are postmenopausal, you should go on estrogen. It's really an individual decision.
Okay.
There are different types of hormone replacement, kind of for localized symptoms, if you will, and then for also generalized symptoms, whether pills, creams, there's many different types.
So there's a lot of different options as how to absorb estrogen.
Yes.
And if you're going into your doctor's office over the age of 50 and you're a female, they're not going to be trying to push estrogen on you. They'll be trying to do some education and give you some options. Maybe do a bone density at that time. And
correct. If you're postmenopausal. Perimenopausal means you're still, which can be, sometimes it's upwards of 10 years before you actually go through menopause, and you can have a lot of those vasomotor symptoms, hot flashes, dryness, things like that. So we can think about treatment at that time. But as far as a guideline or a recommendation or a screening for it, there's really no hard and fast rule about it.
Excellent. And I feel like my job as a registered nurse and my job is the same as a patient would be, is I would report any changes to you or to their primary care physician. And quite often I find that people are saying to me, well, it's only been this way for a month, or I've felt this badly before. But generally what I like to tell people is if something's changed, call and report it. Do you agree with that?
I do. Yeah, definitely. It's always good to run it past, your medical provider, somebody who
Yeah.
hopefully knows you.
Yeah. So anything in your health status, if it's changing, if you feel more fatigued, if you're having aches and pains, even if they're general, things you never ignore is a fever, a rash, general malaise that lasts for more than 48 hours where you're just feeling tired and sick. You know, these are the kinds of things that people just want to blow off, but it is important to just call you up. And how receptive do you feel your office is to receiving calls about those kinds of things?
Oh, I think, yeah, very receptive. I mean,
Yeah.
we're a busy practice, but, you know, we have walk-ins every day, and we try to get
Yep.
everybody seen.
Yeah, and I feel that way. I think we're very lucky in this area of the Cape that, you know, physicians from all the way down to Wellfleet and Hyannis that I deal with are always happy to get a phone call to say something's changed, and then they're aware you're on their radar, and they might just give you a follow-up call, you know, at the end of the week and just say, you know, how are you doing? Has anything improved? And then just see if you need a follow-up. But communication with your primary care is very, very important.
Very important, yes.
So thank you so much for coming
Thank
out
you.
today. It really is a pleasure to have you come on.
Thank you very much.
All right, thank you again, Kim Irvine.